One question about trials, another mutation that I think we're just starting to talk about in the ER positive setting. In the ER positive HER2 setting, HER2 negative setting, apparently there's a certain percentage, a low frequency, probably under 10%, although we're not sure, of HER2 mutations.
3%.
2%. Well, it's 3, but some people think it's more. I mean, you have Matt Ellis's data that says 3. Oh, your data?
No, not Matt Ellis and Cynthia Ma who are doing that trial. I think they think it's still really low, 3%.
But who knows? It could be higher. I think that we don't know. I mean, anyway, but be that as it may, assuming it's 3%, because, for example, from lung, ALK is 4%, so this is significant.
I don't think 3% makes it not significant. I think the foundation data suggests it's really low too.
So assuming it's 3%, will there, do you think, be a role for anti-HER2 therapy, tyrosine kinase inhibitors or the like?
I think it depends on the magnitude of the effect of the drug. If the drug made a major difference, like in ALK translocated tumor, I agree. If we have, let's say, 10-12% objective response rate,
it's actually, I think, becoming a more and more interesting study, area to study, because it turns out that these mutations are primarily seen in ER positive and in lobular cancer. And we've all seen this subset of lobular cancers that seem to be very resistant to therapy. ER positive, they relapse, they don't do well, they get visceral disease early. And so it may be that those patients represent the larger percentage of HER2 mutated tumors. And there are plenty of now case reports of very nice and durable responses to neratinib as an oral tyrosine kinase inhibitor. So, and that was modeled in the preclinical setting. So actually I think it's kind of an interesting area. Maybe in the future we're going to be focusing more and more on these very small subsets.
2 drops of water into the wine. Before flying to the stars and go for these exciting new biomarkers, which we have to do, and we have translational programs in all of our studies, I think we have to go back and do some homework in our local pathology. ALTO trial, 8,000 patients, GEPA-4 study, more than 600 patients HER2 positive, and including ESTINET. The rate of locally HER2 positive, centrally HER2 negative is between 15 and 20%.
It's huge.
Now, in the setting of early treatment, these patients receive chemo and trastuzumab. At least they don't receive the wrong treatment. But for TDM1, it is crucial to be HER2 positive.
Yes. I agree with
TDM1 is the only treatment. So if you treat them with placebo, then they have a problem. So again, please, homework, local pathology, we have to improve.
So do people in Europe use copy number like they do in the US now?
FISH.
For HER2, copy number FISH?
But not in all patients. We still have the algorithm, IHC3+, you have to believe it. IHC2+, then we do FISH or FISH.
That's what's basically accepted. In our countries, it's possibly an exception. We are doing both.
And do people treat, do you guys treat equivocals, say with a copy number greater than 4?
That's a manager question.
Well,
or ratio 1.8?
I mean, that is the problem.
This is the problem.
You raise the new,
I don't.
I don't. No,
I don't. Do you?
I do, yes.
I don't treat equivocals because I don't think there's any data to support it, but we do treat patients who have a copy number of greater than 6 who don't have a ratio over 2.
Right. It's a really fascinating question. One last question.